You are now listening to Nailed It, the Orthopedic Surgery Podcast.
Dr. Khafaji, welcome, I guess, back to the Nailed It Ortho podcast. We had you before one time. Then I was telling you before, my computer crashed. This was a couple years ago, so we're glad that you came back, and we're gonna talk some more, on the podcast. So welcome to the podcast.
Yeah, thanks for having me back. I guess the robots can't take over if they crash. So,
Right.
maybe it's a good checkpoint for us today. But it's good to be back and talking about hip preservation.
Yeah, and we were briefly talking beforehand, but when we spoke the first time, you were actually here in the States, but now recently you've moved, recently being within the past couple of years over to Australia. Can you kind of tell us what is that like? Any differences, big differences that you've seen between, working in Australia versus working in the US? We actually have a good amount of people from Australia that listen to the podcast, but just interested to know.
Yeah. So, in regards to the experience of immigrating over here, it's a lot of hard work, and it's it's a massive administrative hurdle, and it's not for the faint of heart. So, I don't recommend it unless you have a good reason to come here. It's almost another podcast within self medical immigration. But it's from a practice perspective, it's very different. It's ironically, our neighbors to the north in the U.S., Canada has almost the opposite system of what we have in the U.S., which is a purely capitalist-based system for the most part. We have Medicare and the VA and things of that nature, while Canada's purely what some people will call single payer or socialized medicine, depending on your definition. And here in Australia and also New Zealand, that have a similar medical system. It's a bit of a balance between the two. We have a public sector, which is kind of the foundation of healthcare here in Australia, and everyone has access to that if you are a citizen or a permanent resident. And then you have the private sector, which is different hospitals and surgeons and doctors work in both settings. And in the private sector, you have benefits such as not, picking your surgical dates, picking your surgeon. While the public sector, while it's free, you don't get to choose your surgeon. You're on a wait list, things of that nature. So it's kind of the best of both worlds in some ways, but it does come with some flaws, such as wait lists and certain expenses in the private sector. There's no perfect medical system, but it's different, and most people here are relatively satisfied, I would say, compared to our North American counterparts with the healthcare system. But there's always things that need to be improved upon.
Yeah. And are you still able to do kind of the same kinds of cases that you were doing in the States over there?
Yeah, so the answer is generally, as a general orthopedic surgeon, yes, there's always small trends in different procedures and philosophies, no matter where you go to. I've also have had the opportunity to work a bit in Europe, and things here historically, there were heavy utilizers of like navigation for total knees.
Yeah.
Well, before the US got into it. But at the same time, ACLs here, are typically done with hamstring grafts. There's almost very few people doing allografts here, but they have synthetic ligaments here that some surgeons use, which is very controversial. So there's like all these little details that are different and interesting when compared to the U.S., and it kind of makes you think a bit outside the box. Even though the U.S. is a very big state,
Yep.
sorry, very big country with many states, but there's still philosophies that even though we have a very diverse educational system, especially in orthopedics, regarding locations and mentors. There's definitely a bit of an American way of doing things, and there's things that we do a bit differently here in the Southern Hemisphere. But at the same time, it's just different philosophy. It's not wrong, it's not right. It's just a bit different, and it makes you appreciate the pros and cons of everything that we do.
Yeah. Yeah. Well, that's awesome. I'm glad you're I'm glad you're enjoying it out there. Hope it was a good move. Actually, I know a couple, and at least I know a surgeon or two that was here in the States that have moved actually to Australia. No, New Zealand, actually. Never mind, not Australia, New Zealand.
Oh, you
Um,
don't make that big mistake. That's that's like calling a Canadian American. You can get in trouble
I
saying that.
can't do that.
Yeah.
Oh man. Well, let's go ahead and switch gears and talk about a little bit of about hip preservation today, or a little bit about some hip dysplasia, and so we know it kind of comes on two different sides, the femoral side and acetabular side. Can you kind of take us through like acetabular dysplasia? What is it? How how do we know what it is, and how do we evaluate for it? Like, what can you kind of take us through some of that?
Yeah. So, the hip in general is fairly it's a bit of a black box in regards to presentation sometimes. Compared to the knee, it's knee's a bit more straightforward. Patients come in with MRIs and you see torn ligaments that have an acute presentation. And you get a lot of information relatively easily with other diagnoses and other joints. The hip is a bit more vague. Very rarely do you get, acute hip injuries. They're more kind of subtle presentations, and you kind of really have to work out finding the pertinent details to make a diagnosis. So for hip dysplasia, typically, we see younger patients that have groin pain, but it can also be lateral hip pain as well, that have pain with just generalized activity, but especially standing. And what occurs is from the pathoanatomy of hip dysplasia is there's limited coverage of the femoral head via the acetabulum, and those abnormal forces that are experienced in the articular surface of the hip innately create pain. And the long-term consequence of this is accelerated arthritis in this population. And basically, it's very important to not only listen to the patient, but get a good exam and also evaluate your imaging to really put this all together and make a diagnosis of, symptomatic hip dysplasia. And it's a very much a spectrum. It's not a kind of a categorical yes or no. You have hip dysplasia that's symptomatic. It can be a piece of the puzzle of what's wrong with the patient as well. And you really have to very thoroughly go through, a very detailed history and physical exam to kind of allude specifically how much of this is coming from the patient's anatomy.
Yeah, and when you just mentioned kind of what's coming from the patient anatomy. So what are some of the anatomical things that could lead towards like hip dysplasia, or yeah, hip dysplasia? What are some of those anatomical things that we're looking at or trying to figure out?
Yeah, so for the purpose of this talk, we're going to focus more on adult hip dysplasia, the skeletally mature hip. When you get to the open triradiates and open physes of the pediatric hip, that's almost a completely different subject. So when I think of hip dysplasia, like I said, it's on the spectrum. And what we typically see on an X-ray is you have the classic lateral center edge angle of less than 20 degrees. And what this basically implies is that the superior anterior wall of the acetabulum is deficient. Now, that being said, this is only a piece of the puzzle. The acetabulum is a three-dimensional structure. It has anterior wall, a posterior wall, and then it has the superior facet. And all of these pieces can be within themselves dysplastic or malrotated, such as a case when you have acetabular retroversion with a normal global coverage, but a disproportionate overcoverage of the anterior wall compared to the posterior wall, which can cause impingement. So you have to really appreciate being a hip preservation surgeon, getting good X-rays, and really understanding the fine art of reading X-rays to evaluate the hip to make a diagnosis of hip dysplasia. Now, the classic lateral central edge angle of less than 20 degrees is considered dysplasia. And then you also have this group that historically has been called borderline dysplasia, which is between 20 and 25, with above 25 being a normal lateral center edge angle. Personally, I don't like borderline dysplasia as a nomenclature. I like to call it mild dysplasia because that's what it is. It's not frank dysplasia. It's a very mild form of dysplasia. This hip is painful, but it's not going to go through this kind of classic this classic aggressive degeneration of a symptomatic of a severely dysplastic hip. And these patients innately are the ones that we have a hard time creating an algorithm for, and we're having a lot of controversy on what to treat them with, whether it be a hip scope or PAO, which we can talk later. But, as I said before, the most important thing when evaluating a patient regarding radiography is getting a very good AP X-ray, both in supine and standing. Standing kind of shows you the anatomy when the patient's most symptomatic, typically when they're standing, and then the supine X-rays to help you if you decide to operate on them to reproduce imaging that you will see when the patient's on the operating room table with your fluoro to make your correction.
Yeah, and a couple of things that you mentioned. So, just to reiterate, you mentioned the lateral center edge angle, and for those of you that don't know, that's kind of that angle where you get a line from the center of the femoral head going straight vertical, and then you get another line going to the lateral extent of the acetabular sourceal. So it's that angle that you're looking at, and that's the one that I've actually seen a couple of questions on that they ask us. Or at least they used to ask me when I was in residency on the OIT. Thank God I don't have to take that anymore. But they used to ask us that on OIT. So you mentioned the lateral center edge angle. You mentioned when you're getting X-rays, you get X-rays in the standing position because that's kind of where they're symptomatic, and then you also do a supine because that's where if you decide to operate on them, you want a reproducible picture. Since we are on X-rays, anything else that you look for on X-rays as to how we can evaluate these, and then I guess in the adult population?
Yeah, so the one thing that kind of carries over from the pediatric population is Shenton's line, which you can see from the inferior aspect of the femoral neck, and it continues into the inferior portion of the pubic rami on an X-ray. And when you have a break of Shenton's line, you can tell that this hip is in crisis. This hip is either subluxing a bit, or it's frankly dislocated. And these hips typically require more surgery, whether it be a femoral rotational osteotomy to help with containment, or a shortening femoral osteotomy if it's a frank dislocation, which is obviously a separate talk within itself. So I'll look at that, and that can really capture the kind of the bit harder cases to go through. Another thing I like to look at always is a done view to evaluate any signs of impingement or cam lesions, which can occur in dysplastic patients. And those patients, obviously, if this is part of their if they require PAO, you need to think about potentially taking down their femoral head neck offset to prevent any impingement that's caused from your correction, because that can happen. You trade one form of hip pain for another. Another thing is the anterior center edge angle, which you typically get with a false view, and that can show your anterior wall coverage. And this is taken from a measurement standpoint in a similar fashion as the lateral center edge angle. And then finally, this is based on CT, but sometimes I would get a CT of the hip and knee to calculate hip anteversion, which sometimes requires to be corrected as well in patients, like I said before, that are maybe subluxing a bit, and we need to help them with their containment, and we need to do a rotational osteotomy to correct their excess hip anteversion.
Perfect. Yeah. So to recap, you mentioned, you get your APs, your standing, your supine APs. You mentioned Shenton's line, which is a kind of that line going on the inferior neck, and you want to make sure that that lines up. If that doesn't line up, there may be some type of subluxation. You also mentioned the done view that you get, and that you're looking more for cam lesions. Can you just quickly explain what the head neck offset is? And what we have a lot of, sometimes we have some interns and second years listening to this that may not 100% know what that is. You mind just explaining what that is?
Yeah, so offset basically means a step off from a high point to a low point. So in what's called, what some people call abnormal hip pathology, this is relatively normal hip pathology. It's just a variation of normal that puts some patients at risk for hip pain. But in a low head neck offset, basically the highest point of the femoral head is relatively close to the lowest point of the femoral neck, i.e., there's not much space between the two. So when you flex your hip up and internally rotate, the acetabulum tends to hit the junction of the femoral head and the femoral neck because there's not enough space. When you have high head neck offset, which you see, more likely in the normal, quote unquote, normal patient population, there's a bit more space between the femoral head and the femoral neck. So there's a greater arch of range of motion, and you really need to flex your hip more to get that bony impingement between the femoral head, neck, and the acetabulum. So we can measure this, with a measurement that evaluates head neck offset. But more commonly, the done view is used to measure an alpha angle, where you take a line through. You take this 45-degree done view. You draw a line from the middle of the femoral head down the neck, and then you take the other edge of the angle, which is right at the head neck offset, basically where the sphericity of the head is lost. And that basically is analogous to how much reduced head neck offset you have. Typically, the normal value is less than 45, and then you start thinking of an actual cam lesion when the alpha angle is above 52, 55. It's debatable, but typically above 55 is considered a cam lesion.
Okay, perfect. So you got the 45-degree done view, and you measured the alpha angle and the head neck offset like you just mentioned. And you also mentioned the false profile view, which is more for the anterior acetabulum, and you're getting the anterior center edge angle, which if you think lateral center edge, this is just more for the anterior part. So you get a line going up the femoral head, and then another one going up like the anterior aspect of the acetabulum, and that's going to help you measure your anterior coverage. And so I guess jumping around here a little bit, you spoke a little bit earlier about when they actually present to your clinic. They mostly kind of present with some like low back pain, some hip pain. What is your exam like in the clinic? Like, how are you examining these patients? A lot of time, I remember, at least it would have seemed like when I was like a medical student or early resident, that the attending would just flex the hip and then turn her in and out a little bit, put it back down, and then you'd have exactly what the diagnosis was. And I was like, how did you figure that out? So can you kind of take us through how you figure these out as far as, the pertinent things on the history and pertinent things on the physical?
Yeah, so I basically, for every hip patient that's not an arthritic hip, I examine them all the same way to try to elude what exactly is causing the pain, because you can have, for example, trochanteric bursitis or an external snapping hip with hip dysplasia. So this is potentially a cause of patient's hip pain. So you need to be able to find that stuff out. Don't try to get blinded by your X-ray findings. So to make a long story short, the first thing I do is get a Baton score from them to check their laxity, which in this patient population, you're more likely to find a hyperlax patient. And then I evaluate their lower back and do a straight leg exam to see if there's any radicular or lower back causes of their hip pain. And then I will go through a range of motion of the hip flex their hip and internally rotate it to see if they have any pain or if they have any impingement symptoms within itself. And then I'll abduct their hip to kind of check their range of motion to see if they elicit any pain from an excess range of motion point of view, which sometimes you can see in ballerinas. They get more pain when you abduct their hip, and then they start impinging once they get to 90 degrees of hip 90 degrees of hip abduction. So it's these unique presentations you have to capture. Then after that, I evaluate their abductors and their trochanter to see if they have any tendonitis or weakness in their abductors. I ask them to stand on one leg and do a one-legged squat to make sure that they have good core control, good abductor control. And then I evaluate check them for any signs of ischiofemoral impingement, deep gluteal symptoms, sciatic nerve problems, SI joint pain. It's a very long and intense exam to try to elude all these little things that can potentially be part of their pain. Now, things that you find specifically in hip dysplasia typically is if you ask them to stand on their symptomatic leg, they'll get pain. And when you generally do gentle hip range of motion, they'll get pain specifically in their groin. And that's kind of what makes me think of that picture, along with their x-rays, combining them together, that this is a patient that has symptomatic hip dysplasia. And that can also be confirmed if their symptoms improve after an injection that you can do in the clinic or ask your radiology colleagues to perform.
Okay, perfect. Yeah, that was a great overview of the hip physical exam. Those of you that are listening, hope you rewind those last 3 minutes and listen to it again and take some notes. That was gold. And so say for example, we have this 24-year-old female, comes in complaining of a little hip back pain. You do your physical exam, you're thinking that she may have some dysplasia. You get your x-rays and the lateral center edge angles like 20, the anterior center edge angles, let's say, is at 20 again. The hip isn't really sublux. There's not a lot of arthritis. Basically what I'm asking is, how do you go about managing it? Where do you go? Like, what's the treatment algorithm that you typically use?
Yeah, so I'm the surgical treatment for a dysplastic hip is obviously a PAO, which is a big deal. It's a big surgery. It takes a lot of time and effort from the patient to recover from. So I like to keep a close eye on these patients and just get an idea of what's going on in their life. Is this an athlete that needs to play sport for a couple more years? And that's the case, then I'm going to try to aggressively treat them with conservative management, and that will be strong core strengthening exercises, a lot of focus on their hip flexors and abductors. The psoas tendon is a primary stabilizer anteriorly, a dynamic stabilizer anteriorly of the hip. So we really try to have them work on getting that strong psoas to kind of push their hip toward the acetabulum. And we also work on their neuromuscular control as well in physical therapy. If they have pain, we provide them an injection. And then we see what they want to do in their life. Is there's things that are aggravating their hip that they need to slow down with. Should they not run? Should they, slow down with their sports participation? Because potentially that could give them a lot of pain relief and not go down this surgical pathway. Now, if they were to fail all those modalities, and then I would sit down and discuss with them, surgery such as PAO or hip scope, depending on what pathology we're evaluating.
And so which ones are you going more towards we didn't mention getting MRIs, but say we're getting MRIs and they have a labral tear. Which patients are you leaning towards? Okay, let's try to maybe treat this with a hip scope and see if we can fix your tear. And if they have a cam lesion, like you were mentioning a little bit earlier, take that down. Like, which ones are you going for hip scopes? And then which ones are you going more towards the osteotomy, the pelvic osteotomies?
Well, let's go back on the MRI. So what is the what is the use of an MRI, in treating, making your decisions for a dysplastic hip? In my mind, an MRI is to confirm that this hip is a good hip for surgical intervention. MRIs are not really reliable in identifying labral tears. I can tell you, I have seen a lot of hips. I go in there and I see a tear, and it was not picked up on an MRI. And the reason why is, standard MRIs are single plane. You have sagittal, coronal, and axial view, but the acetabulum is circular shaped and it's not in a line with any of those views in any typical protocol. So it's very difficult to truly to really capture all the labral tears, even with an MR orthogram in the general population in a general imaging institute. So an MRI purely is to identify what is the cartilage status of this hip. Can I find subtle edema? Maybe, every once in a while you find a patient that they have AVN, and that's a different can of beans compared to treating a dysplastic hip. So it's just to confirm that this is just biologically a very healthy hip, other than the anatomical issues that we've discussed before. That's what I use it for. That's what a lot of people typically use it for.
Okay.
Now that looks good. Then if the patient has severe hip dysplasia, an a lateral center edge angle of 20 or less, they typically need a periacetabular osteotomy if they failed conservative management. Hip arthroscopy in that group does not do well in isolation. Now, what's becoming more popular is we like to, even with an MRI, what we like to do, including it's relatively controversial, but a lot of more people are going in with a hip scope either before or after the PAO to repair labral tears, to do a femoral plasty, to deal with the intra-articular issues of the hip that potentially can prolong the life of the hip. Now that's relatively controversial, but that's not the only thing that you can do. The power horse of treating symptomatic hip dysplasia is a periacetabular osteotomy, because that's innately what corrects the biomechanical problems of what's causing the hip pain in this case to begin with. So personally, that, for any test taking questions, a symptomatic dysplastic hip should be treated with a PAO. Now, the mild or borderline hip dysplasia case, that's very controversial, and a lot of it's based on what you're comfortable doing. The definitive treatment for any dysplastic hip is a PAO, but some patients, they can't invest time in dealing with a PAO when the dysplasia is mild. So you might try to perform a hip arthroscopy with a capsule plication, where you put some sutures through the capsule and you tighten up the hip so that there's more innate stability, soft tissue stability of the hip. And some reports show fairly good outcomes with this, but many would argue that this is a Band-Aid, that eventually your biomechanics are going to catch up with you, and the hip is going to eventually require the ultimate surgery, which is a periacetabular osteotomy. So that cohort is still controversial. We're still trying to figure out what's the best course for them. But at the end of the day, when you have a severe dysplastic hip, you have to do an osteotomy to treat them definitively surgically if they fail conservative management.
Yeah, and in the osteotomy, I think I remember reading one time a question that asked us which column was left intact, and could you kind of go over just overall this big picture what the osteotomy is? I know there's a bunch of different types of osteotomies, and like redirectional versus reshaping and whatnot, but what is the main one that's typically used?
Yeah, well, and so the more variety, like the Salter and the triple, those are typically ones that you see in the pediatric
Yep.
world. In the world of adult hip dysplasia, the workhorse is the Bernese or the Gans osteotomy. Gans is a retired surgeon in Switzerland, and in the mid to late 80s, he developed the periacetabular osteotomy, which bears his name. And what this unique osteotomy does is that it keeps the posterior column intact while still reshaping the deformity within the joint. But before this, many people would do these other forms of osteotomies, which have their own complications and are more difficult to correct. This one, after getting through his learning curve, he's shown that there's been good longevity of this osteotomy, up to 30 years. I believe it was 60% of preserved hips after 30 years of performing PAOs in his case series. And what it basically is making a cut through the ilium, through the ischium, through the superior pubic rami, and down the posterior column, while keeping the posterior column next to the ischial spine intact. And after you do your correction and put in your screws, you don't need to protect weight bear for a long period of time, because you still have the posterior column intact, which accelerates your rehabilitation significantly compared to taking down the posterior column and having an unstable hemipelvis, which is obviously a bad outcome.
Right.
So the uniqueness of the periacetabular osteotomy and why it's used as a workhorse for osteotomies around the acetabulum currently.
Awesome. Well, Dr. Khafaji, I thought this was great. You know, we talked about kind of what you're looking for on imaging, how to evaluate the x-rays for patients. You know, when we're talking about hip dysplasia, we talked about their history, we talked about physical exam findings, and then we talked about the treatment. You know, we mentioned hip arthroscopy, we mentioned different types of osteotomies. Anything else that you want the people to know about hip dysplasia that you think is beneficial before we wrap up here?
Yeah, the only thing I would add is a variation. We talked about it briefly, but a retroverted acetabulum, which, as we've said, is a normal coverage of the hip from a volume standpoint, but it's a deformity of where the posterior wall is deficient, but the anterior wall is overcovered. And symptomatically, patients present similar to what an impingement case will present as, and they'll have an anterior center edge angle of that's high, let's say 40. And then on an AP view of their hip, you see a crossover sign, but you also see what's called a deficient posterior wall, where the posterior wall doesn't cover at least half of the femoral head. And in these cases, these are unique cases, because these can also potentially be treated with a very simple periacetabular osteotomy as well, or a hip scope, depending on what literature you read. But if you really want to truly correct the deformity, this is another form of hip pathology that can be treated with the periacetabular osteotomy. I'll just kind of leave that for your listeners to think about. And then the last thing I would say, for the trainees out there is, to think about, this kind of new field of orthopedic surgery, which is hip preservation. It's very exciting, and there's a lot of demand for it out there. And it takes, it's almost like what arthroscopy was in general, in the 80s and 90s. There's a lot of things that are changing. We're learning more, and the more that we learn, we are starting to understand that we can do a lot to help these patients. And it's very exciting, and I would consider have your listeners consider a career in hip preservation going forward.
Yeah, definitely considered. I didn't have much hip exposure before fellowship, and here we do mostly hip arthroscopy. But every now and then I'll see a case that's on the board for a osteotomy. So there are people doing it for sure, in a very interesting field. And again, thank you so much for coming on the podcast. Really appreciate it. Really learned a lot, especially thinking about the acetabular retroversion. One quick question about that, actually. Do they tip is the pattern of wear, or I guess possibly the pattern of where the labral tear is different than your normal, non-retroverted, where it's mostly anterior superior tears on the labrum.
Yeah, so you might sometimes see with a retroverted acetabulum, see more labral tears lower down the clock face, moving close down to 3 o'clock. But what you really appreciate in a retroverted acetabulum is the quality of labrum typically is a bit more beaten up, a bit more degenerative um, compared to let's say a typical cam lesion labral tear, where there's good substance, but it's being peeled off the rim. So those little subtle differences that you see in your diagnostic arthroscopy also lead you to understand, well, this is a tear that we see more in the sense of pincer impingement, and this is kind of going more down the path of the retroverted acetabular retroverted form of impingement compared to those peel off tears that you see in cams. So it's not only the location of the tear, but it's also the quality of the tissue and the kind of tear that you see that makes a big difference when you look at it intraoperatively.
Yeah. Great. Well, thanks for that. And again, thank you so much for coming on the podcast. Those that are listening, please go and leave us a review. Let us know how much you enjoy listening to this episode, how much you learn. I always learn a ton of stuff every time I do one of these podcasts. I hope you all learn some more. And again, Dr. Khafaji, thank you so much for being a guest on the podcast.
Anytime.